Our next speaker is Sarah Sparham, who's one of the infectious disease registrars at the Austin, and this very issue about, the attitudes about medical staff and their non-compliance, and where was the issue? Was it bad leadership, or was it at the level of the resident, or was it something else? And so we funded Sarah in a break in her training for a bit to just follow a whole lot of medical staff around on their ward rounds and see what the behaviour was like on the ward rounds. So that's what Sarah's going to present to us, and you'll be surprised by the findings. Thanks, Sarah.
Doctors do lag behind all the other groups historically and still today. And at the Austin, in our first audit period this year, the medical staff overall had a compliance rate of 71% compared with whole hospital of 82%. And there's a lot of reasons this may be. In some cases, it may be genuine lack of knowledge about the 5 moments. Some feel they're too busy, they're distracted, it doesn't really matter for them, they're not actually touching the patients, they don't realise what they're doing at the time. And unfortunately there is still a little bit of scepticism around regarding the importance of hand hygiene. So ward rounds are sort of a special case in the hospital in that they go from bed to bed, from ward to ward, in and out of isolation rooms, and really if hand hygiene isn't vigilant, they're a perfect vehicle for moving infection around the hospital. But they're not really captured particularly well by standard auditing methods because they tend to be location-based. So you go and audit on a particular ward on a particular day. Doctors might move through and you'll pick them up opportunistically, and that's that. Which doesn't allow us to sort of examine the particular behaviour on ward rounds, and also means we can't gather data on specific units very efficiently, unless they're based on one specific ward, which in some cases happens. Doctors tend to move ward to ward, and so you sort of only pick up some of their behaviour. Ward rounds also have a lot of different variables which can affect compliance, apart from just individuals. There's time pressure, so particularly some surgical ward rounds see a lot of patients in a short period of time, and I'll give some data on that in a moment. And also there's different sort of hierarchy and different staff on the ward round. So you can have anything from a couple of registrars, a registrar and intern, to a ward round of sort of 15 people with several consultants, allied health, different levels of junior doctors. And different ward rounds also see different patient populations. So medical staff may not have to undo any dressings on a ward round, whereas a busy surgical ward round may take down multiple dressings, which obviously changes the sort of moments. So we decided to look into this specifically, and our question of our study was to investigate whether there are particular medical units, training levels, i.e. consultant, registrar, resident, intern, or in fact individual practitioners with poor compliance, by auditing on ward rounds, and then subsequently we, on the basis of this data we've collected, intend to design an intervention, but at the moment we're just at this first part of the study. So we measure compliance based on the 5 moments I set out by the World Health Organization to try to establish what barriers there were to good compliance by medical staff, and then find some opportunities to intervene. This was a prospective audit, and we selected units with high patient load. We couldn't follow all ward rounds, obviously, because a lot of them happen at the same time. So we selected ones with high patient load, so general surgical rounds, general medical rounds, units with high-risk patients, so immunocompromised patients such as haematology, oncology and liver transplant unit, renal, who have transplant patients, and also units who had high-risk practices, so units with a lot of dressings on the round, such as plastics and vascular. It was a single auditor, that was me, so I underwent the hand hygiene accreditation at the Austin, and it was in a sort of unique position to be able to do this. I've been at the Austin for quite a long time. The different units are used to seeing me around on the wards. And there was sort of a bit of a sweetener in terms of their acceptance of me on the ward round, and that they could ask me for advice on antibiotics and so forth. So they were generally pretty happy to have me around from that point of view, which I think helped a little bit. Now, all of the units, as in the heads of units, were made aware of the audit beforehand. And the majority of the time, the staff in the rounds were informed. Now, there were a couple of cases where I tagged along to a ward round which was sort of sweeping along, and nobody really noticed I was there. But for the most part, they were aware I was there. They knew what I was doing. So just keep that in mind when you see the rates of compliance that come up. So this is the form that I used, just to show. We just essentially adjusted the normal form so that there was more space to record other data, such as the individual, which unit it was, and any other factors at that particular moment, so whether it was an isolation room, that sort of thing. In this case, there wasn't any hand hygiene, because the hand hygiene was affected by there being no alcoholic hand rub because it was a bariatric bed which has no capacity to put that on. But actually, for the most part, availability of hand rub was not an issue in this audit. So I collected 650 moments of 15 units, spread across medical, surgical and subacute, and I'll show you the spread in a moment. As I said, most teams were pretty receptive and engaged, so I've experienced very little resistance. Some of the surgical units kind of ignored me. A lot of the medical units were really happy to have me and were asking for feedback. So I didn't provide at the time feedback, but if I was asked to provide feedback at the end of the round, then I did so. But it was fairly well received as an exercise. And this is the spread of the audits. So in the sort of orangey, yellow, red colours, those are the medical teams, and the blue of the surgical. So those two teams are about even and made up the vast majority of, so those two departments made up the vast majority of the moments contributed. Liver transplant's a bit of a special case in that the ward round has both physicians and surgeons, and then subacute in green contributing a smaller proportion. So these are the percentage of moments overall. So not unexpectedly, most were moments 1 and moment 4. With 2 and 3 being a much smaller proportion of the moments. And this is compliance by moment, which is concerning. So moment 2 is probably one of the more important moments in that you're about to access a clean site, and then moment 3 after potentially accessing a contaminated site. Now, I will say that with moment 2, about half of those misses, they were wearing a clean pair of gloves. They just hadn't alcohol rubbed appropriately in one way or another. So it's not a complete disaster, but it's not compliant with the 5 moments. And this is the percentage of moments contributed by each position of the people. So we've got the heads of units in the dark red, the consultants in the bright red, fellows which were pretty negligible, and then the vast majority was registrars. As you can see, the HMOs and the interns actually contributed very few moments, and those there were often moment 5, so they'd gone in, touched a drug chart or something and walked out. They very, very rarely actually laid hands on the patient, which is an issue in terms of their education, but from our point of view, it's an interesting point because that's often where education is targeted in the hospital. So when the interns come in during orientation, or they all have weekly education and they're told about sort of thing, but they're not actually contributing to most of the problem because they're not really touching the patients. Whereas the registrars obviously are the ones who are doing this the most, and by the time they've gone through orientation at the start of the year about 5 times, they're not really listening anymore. And then their education through the year is much more focused on their particular specialty, not the sort of thing like hand hygiene. This is compliance by position. So the fellows, which are the poor performing one there, you can sort of discount because they were very few moments. You can see the rest of them were actually pretty even. So I think there's been a bit of thought that the more senior people in terms of medical staff don't necessarily perform as well, and I know that there have been studies in the past which shows if a senior member of the ward round performs poorly, then the rest of the team tend to do so as well. But we found that actually the heads of department consultants were doing pretty well at the Austin, and if that would have been actually a little high if it wasn't for one particular member of staff who pulled that down a little.
Whose name we could give you for a certain price.
Yes. Yes, I could. See me after. Was the registrars who are really performing most of the moments are coming in at 61%, so well below the benchmark that we're aiming for. HMOs and interns not doing too badly, but again, not really contributing most of the moments. And this is the compliance by the different units. So if you look at the medical units, they're performing pretty well. A lot of them are actually above benchmark. Infectious diseases performed well, I'm pleased to say. And for 1 week, a certain consultant in the room was on the round, so he did help with that. Renal didn't perform as well, and that I think was a combination of the fact they've got a lot of patients in isolation rooms, a lot of people with VRE, but also certain members of staff were pulling that down as well. The surgeons overall did perform more poorly than the physician units. General surgeons, not as badly. They were often registrar-led ward rounds with smaller numbers of staff. Whereas the specialty units, so orthopaedics, plastics and vascular, really were not performed particularly well. And they did have a lot of patients with dressings. They often had very large ward rounds, up 8, 10, 12 staff on the ward rounds, which makes it physically difficult potentially to get to the hand rub. And often very sort of rapid ward rounds, getting around a lot of patients in a short amount of time. Subacute were doing pretty well. You'd hope in a way that they would, because they spend a lot of time with each patient. They're not under much time pressure. They've got time to perform their hand hygiene. And then overall, at the end, we've got the combined rates, which was 64%, which was not quite as good as what the medical staff come out overall in previous audit, but fairly consistent with previous figures in previous years. So if we sort of put the departments together, you can see that, as I mentioned, the surgeons definitely do come in well under the medical and subacute units, who individually are sort of getting pretty close to the benchmark rate. So we did collect some of this other data which we thought might be affecting behaviour. So the average number of staff overall on a round was 5. On medical round, that tended to be 3, often a registrar, a student and an intern, or a consultant, a registrar and a resident. Surgical round, the average was 8. And it was often above that, and that's a whole range of people, not all medical. Average patients seen on a ward round was 9, and the average duration was 79 minutes. Medical ward rounds substantially longer, with about 12 minutes per patient, with surgical rounds shorter but more patients, so average of 5 minutes per patient. And the shortest per patient time was orthopaedics, who spent a massive 2 minutes per patient on their round, often with very few moments because they didn't actually touch the patient. And one particularly interesting thing we found, not hand hygiene as such, but an interesting infection control thing. This was the lantern, which was taken by the plastic round around the spinal unit. And it was taken so that they could examine the deep wounds better. So this was placed in the bed so they could see, and then lifted up and placed in the next bed, not cleaned in between. So this is one thing that we did deal with directly as part of this, and that's not being used there. They've gone back to their handheld torch.
Hygiene Australia.
Yeah. And it's the green lantern. So while I was sort of entering all the data and doing the preliminary analysis, 2 things seemed to come out that were associated with missed moments, and that's improper performance of hand hygiene around glove use, and touching the curtains, whether people were either not aware that they'd touched a curtain or not aware that they had to debug after touching a curtain. So we sort of drilled down a bit deeper to see if this was real. And when we excluded all moments where gloves were worn, which was fairly easy to do because that's recorded on the tool, compliance was overall 71%, so it was higher. And compliance when gloves were worn, 47%. So it's a significant difference. And previous studies have found that glove use is a risk factor for poor compliance. And there are some practical issues with that, as in if you just alcohol rubs, then the gloves tend to stick. You have to wait for it to dry, which it should be anyway. And also isolation rooms, it's difficult if you put your gloves on outside and then you have to open the door, and then people don't necessarily then change their gloves, that sort of thing. And just a lack of awareness around having to debug before and after. And so when I was presenting this to our department, there were some of the people saying, well, it is a bit impractical in a quick ward round. Like, it does take up time to change your gloves, and when you've got debug, sticking and so forth. But it can be overcome. There was one particular registrar on one ward round who was not debugging, he was just changing his gloves. And so had a compliance rate of something like 10%. And his resident was not very happy with the way their team was performing and was a bit ashamed. And she said, you've got to debug before and after glove use. Oh, okay. And he did. It didn't disrupt the ward round, didn't take any longer, and his compliance went up to 90%. So it is possible. It's not something that is an insurmountable practical issue. And the other thing was the curtains. Now, I couldn't analyse in the same way as the gloves because I didn't record when curtains were involved with the correct moment. But the percentage of misses where it was because someone had touched a curtain was 20%, so 1 in 5. And if you go back to that sort of subset of moments without glove use, then it was an even higher percentage of those moments. Practically, there has to be alcohol rub at the bedside in order to debug after touching a curtain. But as I said, in this audit, that wasn't the issue. About sort of 98% of the time, there was alcohol rub. Really, it was lack of awareness. Sometimes just they hadn't noticed that they'd touched a curtain, but for the most part, people didn't realise the curtains were contaminated. And really, they get changed potentially once a year. Like they're pretty grotty. So if you combine those 2 things, the percentage of misses involving gloves and/or curtains was 57%, so more than half of the misses just came down to those 2 things. I think the important thing with that is there's a lot of barriers to compliance with doctors. We've spoken about the hierarchical things and being busy and all sorts of things, but this is really awareness, and so it's amenable to education, and pretty simple education. You just have to tell them you need to debug before and after gloves and before and after touching curtains. It's not a complicated message. And we also, I think, found that this sort of targeted audit, rather than just a location-based audit, was able to elicit unexpected factors in poor compliance that we wouldn't have found otherwise. So to summarise in our audit, poor compliance was associated with moments 2 and 3, obviously a concern, and a lot of that was to do with glove use, with surgical units, with wearing gloves during a moment, and touching curtains. And as I've just mentioned, we were able to identify these new targets for intervention, and if we were able to eliminate all the missed moments involved in gloves and curtains, that would have actually brought the doctors overall to above the benchmark of 80%. So it doesn't necessarily have to be as complicated as we think. So as I said, I wasn't specifically giving feedback because we were wanting to get a baseline rate without that. But when it was asked, I gave it, and some of the surgical teams were asking, more often the more junior staff, but there were some of the younger consultants who were interested and were very keen and wanting to know what their rates were and what they could do.
So I suppose when Sarah and I were looking through these data, one of the things which was surprising to me was the pretty high rates amongst the heads of units. Sarah, do you just want to comment? Were there any heads of units who weren't aware of the importance of alcohol hand rub? Or, I mean, obviously their rates look good, but was there any negativity from them? Or lack of executive leadership, I suppose?
For the majority of the units, no. The heads of the units seemed aware, and they were leading by example pretty well. Some of them were a bit old school and were washing their hands rather than rubbing, but that's fine. There were a couple of units, one surgical unit in particular, where the head of the unit was particularly disinterested and somewhat sceptical, and that I think is reflected in the overall unit's compliance.
I just did an ethnography study at a teaching university in the United States, and it seemed to be a tendency for physicians who, a lead physician took ownership of that patient, and there was low compliance among the specialty surgeons or the specialty physicians who didn't, and so my perception was that perhaps it had to do with an ownership of that patient's and an identification of, this is my patient, I will be more compliant, this is somebody else's patient, I'm just here to do a procedure. I see. Right.
Yeah. I mean, we didn't look at that specifically, but I think that probably fits. Certainly, yeah, the physicians and the more junior staff who were involved day to day with that patient did seem to sort of anecdotally have better compliance, whereas the visiting consultants who were just doing, on the ward round, the grand round, had nothing particular to do with that patient, didn't perform that well. So yeah, you may be right.
As Sarah knows, there was one particular very senior physician who was shocking. I think it was 20%. And in that case, I think this is the point about, say, the Vanderbilt model or the others, where if we had gone out and kind of spoken to all the heads of units, a lot of them would have been cheesed off with me because actually they're pretty good. What I need to do is speak to that one individual and show him his results compared to all the other medical heads of units, that he is like 5 standard deviations away from everyone else. And I think that this sort of thing allows that very accurate targeting with data.
I mean, in terms of auditing number of people, consultants were altogether 2/3 of the moment, so we were certainly auditing them. But yeah, this one was a standout, and as I say, it was bad enough that he dragged the whole bar down for that group. I blanked it out, obviously, but
so we know
yes.
every single doctor. So actually, we could send them in by name. Lindsay Grayson, your hand hygiene rate was.
Yep. So we have their individual rates.
Then, if you have thought about looking at the influence of gender.
That's a good question because we have a lot of female surgeons. Actually, I don't know.
Yeah, we do.
We do.
Yeah, no, I mean, we certainly have that information, and we have the year of graduation, the age, all the sort of stuff you can get from medical workforce. So we could analyse for all of that, but we haven't. Just thinking back, I think we do have a reasonable balance, I think, certainly in the physicians of males and females, and yeah, it's male skewed in the surgeons, but the poorly performing physician was a man. Our previous auditing was essentially location-based, ward-based, so for some medical units you could kind of extrapolate, so some are very based on their home ward, but a lot are not, and so no. literally to follow them around is the only way to do it.
I mean, I think the interesting thing about this different auditing technique is it's kind of fits in with how doctors think. I work for a certain unit, what is my unit's rate? But the way we audit, where someone stands in a room, in a ward, unless it happens to be the surgical ward, you can't give unit-based rates. And so everyone's kind of mixed in together.
Yeah. I didn't really encounter any resistance, a little bit of people ignoring me, but they were pretty happy to have me. And the other thing, just going back to the last point as well, is as well as wanting to know their own rates, they were wanting to know other teams' rates and how they sat. So certainly appealing to the competitive nature of some of the units, I think is very useful.
Thank you, Sarah.